Now the program is live.
Yeah, thank you, Chitrakala. Ma'am, with your due permission, shall I start?
Yes, please. Yes, please, Dr.
Thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Sai Lakshmi Dhyan, ma'am, who is very consistently giving her good support for all the educational trainings in the virtual platform. So who doesn't know her when it comes to this virtual platform? She is graduated from Usmania Medical College, Hyderabad, and following this, she pursued her higher degrees in obs and gynecology and gynecological oncology in UK, MRCOG MD from University of Manchester, and subspecialty training in gynecological oncology. And she trained and worked in UK for almost 18 years. And her last post was as consultant in surgical gynecological oncology for 3 years at St. James Institute of Oncology, Leeds, UK. Since she has moved to India in September 2016 and has taken up the post of consultant surgical gynecological oncology at Apollo Institute of Cancer, Hyderabad. Dr. Diana, she is a cancer surgeon and experienced at performing open laparoscopic and robotic procedures for gynecological cancers. And she's also trained gynecologist with 20 years of experience and is an expert in dealing menstrual problems, pelvic pain, and menopause issues. And she's ardent about the promoting women's health and well-being. She has taken interest in making women aware about cancer screening options and risk-reducing options. She is also an excellent health and well-being counselor. So with this, we welcome you for today's webinar, ma'am. And coming to the today's topic, as we all know that hereditary cancers are encountered in all medical specialties. Although they account for only about 5% of malignancies, it is nevertheless important to identify these patients because unlike patients with sporadic cancers, they require special long-term care. So with this, now let me turn over the time to Dr. Sai Lakshmi Dhyan, ma'am, to talk on hereditary cancers. Over to ma'am.
Thank you, Dr. Someshwar. Like you said, often hereditary cancers only contribute to about 5 to 10% of the overall cancers. And one might think 90% of the bulk of cancers are sporadic, and that is where most of the focus always is on. But those 90% of sporadic cancers, sometimes there's not much we can do about it. You know, the cancer happens, we treat. Much as I treat women with cancer, and that is the most of my job, there is so much of pleasure and satisfaction when you actually prevent a cancer or at least screen for a cancer, you know. So much as we operate and we deal with cancer patients all the day, the focus of all of us doctors, all of us gynecologists should be identifying potential candidates who might get cancer and try our best to prevent it. And this topic exactly falls into that category. I'm not going to go very broad because this is such a dry topic and invariably one of the not so interesting topics because so much of it goes above our normal understanding that you start to think, oh my God, this is all a bit too much. So when I prepared these slides, I was constantly thinking, as a gynecologist, what is it that I can do to my gynecology patients when it comes to hereditary cancers? Because the topic as such is very wide, very broad, and very difficult to understand. And therefore, I'm doing it from a gynecological perspective. And at the end of this talk, I hope we will all have some take-home messages, a couple of things we could follow in our day-to-day practice and make a difference to our patients. And so, as a gynecologist, what is it that we can do regarding hereditary cancers? And the first thing we need to do is recognize patterns of cancers in family. For example, you see somebody with a cervical cancer and she says, my mother also had cervical cancer, I'm switched off. Cervical cancer doesn't run in the family, it's caused due to HPV. HPV is predominantly an infective virus. It doesn't run in the family. We don't know any identified mutation. So fine. Okay, 2 people in the same family have cervical cancer, but that's because neither of them went for pap smear. So that's a different story altogether. But if someone tells me there's a family history of breast cancer, my first question to them is, who is this family member? So family history is vital. I take a family history of diabetes, and I take a family history of cancer in every patient who walks to my clinic. And when I say anybody on your mother's side or father's side diagnosed with cancer, and if they say yes, then what cancer at what age? The what age is very important for me when I'm taking a cancer history, because as we go along, it becomes more clear why they got that cancer at what age. So at what's their current age is not important. At what age did they die is not important, but what was their age when they were diagnosed with cancer? And if you notice that this woman, this particular gynecological patient, has a cancer history in the family, and that particular person was young. Or there are lots of cancers. Somebody had bowel cancer, somebody had breast, somebody had maybe stomach cancer, but they were all 2-3 people on the same side of the family. Then you start to think, hang on, is something going wrong with them? And what could you do about it? Fine, you've taken a family history. So what? You need to know what to do when you think something is not quite right with respect to hereditary cancer genes in that family. Then refer them to the geneticist. I work in Hyderabad, and I know in NIMS and certain other government institutes, there are some really good geneticists who give very good advice to people. And if you don't know a geneticist, if you don't know where your nearest geneticist is, at least send them to an oncologist, because we have access to the companies which do cancer gene tests, and they have genetic counselors with them. So once you identify a high-risk family, if you know what to do with them, go ahead. If you're not sure what to do with them, at least send them to an oncologist to discuss their risk, or send them to a geneticist. So that is what you could do as a gynecologist when you come across somebody with a strong family history of cancer. And Dr. Soames already mentioned, so many of cancers are actually sporadic. They happen to because of a mutation in that particular person. But then some cancers are familial, and some cancers are due to hereditary risk of cancer. And now I would really be glad to be interrupted at this stage. I would love it if any of you out there, other than Dr. Soam, could tell me what is the difference between hereditary and familial. To me, they sound one and the same. Hereditary, familial, what's the big difference? Why are we talking about sporadic risk, familial risk, and hereditary risk? What is the difference? What's the difference between heredity and family? To me, they really sound one and the same. So if any of you in the chat box could tell me what's the difference between hereditary and familial before we move on, I'd be really glad, because for many days I thought they were one and the same, and they are not. They are one and the same, but they are not exactly one and the same. And the sporadic cancers, so many of us come across this. In fact, only today I saw a young girl with fibroadenoma in the breast, a 30-year-old, who said she's not sleeping at night. She's absolutely freaked out. She had 2 FNACs done on the same fibroadenoma lump. In fact, I never advise FNAC on a fibroadenoma, which is least suspicious. But she's so freaked out because her grandmother in her old age at 70 got breast cancer. This is very similar to this one person who had a mother or a father or a grandfather or a grandmother in their 80s or 70s diagnosed with the cancer. And one generation completely skipped in this girl's case. The grandmother had it, the parents did not have it, and now she has a fibroadenoma, which is benign. So he said, look, you're absolutely unnecessarily freaking out. There is no increased risk. I clearly said to her, you're not at increased risk due to your grandmother, so please stop worrying. So most of what we see with a family history where one person somewhere has the cancer, no other relative has cancer, that one person was quite elderly when they got the cancer, they are sporadic. What happened to their parents or grandparents was sporadic, and they don't need to be tested for any cancer genes. So sporadic is what we commonly see. But then when it comes to hereditary cancers, you notice that there are several members on a person's mother's side or father's side. There are several members with cancer. Usually the people are in their 50s, 40s, or 60s. And then there's a grandfather, and then the grandfather's brother's side, sister's side, and then their children, and then their children. So you have multiple generations. And you notice that most cancers are breast or ovary or intestines or stomach. And sometimes there's the same person with two different cancers at different times of their lifespan. And then you think, definitely there is something not quite right with this family's cancer history. And these contribute to only 5 to 10% of cancer cases. So if I see 10 patients, only one of them might kind of trigger a family history, which is interesting. The rest of it is all sporadic. So these contribute to a small percentage, but to this small percentage, you can make the whole heaven and hell of difference in their management. So again, I'm going back to the same question, like we decided cancers can be sporadic or cancers can be, there's one chat box, I'm so curious. Not all genetic cancers are familial. What is that? What does that mean? And this is Dr. Sohm who's telling us that not all genetic disorders are familial. Well, I don't understand that well, but we'll come back to it. Okay, how many cancers are genetic? Again, we said that sporadic is 80%, while hereditary and cancer and familial only contribute to 15. And I asked you what's the difference between familial and hereditary. What's happening? Okay, and hereditary and familial are used like one and the same, but they're slightly different concepts. Hereditary is when you actually know which gene is the culprit for that disease. So if you know that, say, BRCA gene defect is the cause of breast cancer in this family, then you say they are hereditary cancers. Or when it comes to hereditary cancers or hereditary disorders, where you know which chromosome, which gene exactly is defective, chromosome 6, this exon is this mutation, then you get this cancer. Then you can test for that chromosome in the future family members, and you can say, yes, we have identified the cause of their hereditary cancers. So when you know which gene is effective, you call it hereditary. And familial is the same as hereditary, but you actually don't know which gene exactly is involved in that defect. So you do their genetic test, it comes normal, all the genes are normal, you can't find a defect, but you can tell something is just not quite right. So that falls under the familial. So familial are those where you think there is something definitely genetic, definitely something running from grandparents to parents to children. Something is definitely happening in that family, but you don't know which gene is defective. Then you say familially something is not quite right. But if you know which gene is defective, then you can say this gene disorder runs in that family and there is a hereditary risk of this. And say this is a family with Bracha. So many families in developed countries know exactly why a certain family member got breast cancer. Are they BRCA positive, BRCA positive, BRCA negative? And if they are BRCA positive, then the other family members can get tested. Now, I'm talking on behalf of this young girl sat on the right side of the screen. Their grandmother had breast cancer at the age of 52. She's BRCA positive. Grandmother's sister, the auntie had breast cancer. She's BRCA positive, and therefore this girl's mother automatically, assuming her mother and auntie had breast cancer, got a prophylactic mastectomy done. And now this girl is young, she's only in her 20s, so obviously she's not thinking about prophylactic mastectomies, but she's undergoing regular screening and some prophylaxis. Prophylaxis against breast cancer can be in the form of medication or it can be in the form of prophylactic mastectomy, and we'll discuss that shortly. Well, if I told you this family, there's also a son to these parents, they sat with their daughter on the beach and there's also a son in that family, what comes to your mind immediately? How do you imagine that son to look? I have a certain imagination in my head. Immediately when I think of a son to these two parents with a daughter who looks like that, I'm immediately thinking another really chubby, roly-poly son. Maybe that's not fair. Maybe the son is absolutely slim and very thin, wiry, but for some reason, immediately you think the son will also look nice and rotund, because there is something going on in that family. Yeah, and something which they passed on to their daughter. Something familial, some obesity gene is definitely running in that family by the look of things. Some real life families are like that. Everybody in the family is very, very obese. And you think it's just not what they're eating and it's just not their lifestyle. They, for some reason, there is some obesity gene, but I can't name the gene. So I can't say hereditary obesity disorder, but I know familially they've got the obese gene. Again, same with diabetes, same with hypertension. If your mother is a diabetic, your father is a diabetic, the chances of you becoming a diabetic are very, very, very high. I don't know exactly what chromosome it is for diabetes mellitus type 2, which goes from parents to children. You know it does. You know, if my parents both are diabetic, you tell me, look, you're at a high risk, you need to watch out, you need to make lifestyle changes. We say that all the time. Same with blood pressure. They are familial disorders, but if you don't know which gene is implicated, then you say they're not, you can't use the word hereditary, but familial, definitely something going wrong. And this can be true with cancer. You can have a family with a very strong history of breast cancer or ovarian cancer or uterine cancer. I saw a lady whose mother's sister, grandmother, and her own sister. So 4 women in her immediate family had uterine cancer. And she came to me asking for a hysterectomy. They are not HNPCC. There is absolutely no colorectal history in their family. There are a lot of other men in the family. And you think, what is it where only uterine cancers happen? Not all of them are diabetic and obese to say that diabetes and obesity is giving them endometrial cancer. Then you start to think that definitely there is some gene defect, but we don't know it. So we just call it familial risk of increased risk of uterine cancer. I didn't do a hysterectomy. I put a Mirena in that lady because that reduces the risk of cancer. So you cannot check for a particular gene. You cannot ask for a gene test, but you know familially there is something not quite right. So yes, there are certain conditions, and as a gynecologist, I'm increasingly thinking, as you read more and more papers on PCOD, they say it could be genetic. A lot of papers are suggesting that PCOD happens right from the age of menarche, and by the time this girl is 20, it manifests itself. It runs in families. It's if your siblings or your mother had PCOD or at a higher risk, then is PCOD a familial disorder? Is there a gene defect with it that we have not yet identified? We don't know, time will tell. But there are so many familial disorders which you cannot test for, but your gut feeling, your sixth sense, your common sense, and your logic, everything tells you that this girl with this kind of family history is at a high risk of this particular disease, and you proactively have to take measures to prevent it. Going back to hereditary cancers, you might think, what's all this she's talking about when the topic is hereditary cancers? Well, I'm just trying to differentiate between familial and hereditary, because you will see a lot of familial disorders, familial cancer associations in your clinic. And when you get their gene test done, they come negative. Then you think, did I get unnecessarily worked up? Did I make her pay 25,000 for the genetic test for it to come back normal? And then the woman thinks, okay, my test is normal, I'm not at an increased risk. But in your heart of heart, you know that there is a very strong family history of cancer and something needs to be done about it. So you need to be clear in your mind that, yes, this probably is not a hereditary cancer, but familially they have something not quite right with them. So you should have that confidence in you to talk to your patient and say, look, there's a strong family history of so-and-so cancer. I can get your genetic test done. Even if the test is normal, I think you're still at an increased risk, and this is what we should be doing. And when the doctor exudes that confidence, the patients take you more seriously. So this is just to tell you that not all cancers which are hereditary can be called hereditary just because we don't know which gene is defective and we cannot identify their hereditary risk on a genetic test. But you know they are at an increased risk, and you need to clarify this to the patient that the gene test might still come normal, but they are still at an increased risk, and this is what they should be doing. A lot of people really take it easy once a test comes negative, and then they forget all the worries they had before the test. So before you do a hereditary cancer gene test, you have to tell yourself that maybe there is no particular gene, and I'll still take care of this patient, and I'll still warn her about her increased risk of cancer. And when you send people, you think, okay, hereditary risk is high. There is a strong family history. So I'm going to send her for the test. But then the test might come normal, or the test might come with some various categories which it can fall under. And you think, what on earth, what's happening here? Why doesn't it clearly say yes or no? That's because of variable expressivity. If two sisters are BRCA positive, only one of them will get a cancer, and you think, what's happening with the other one then? So there's something called variable expressivity, which means in different family members, the gene expresses itself in a different way. So even if you're positive, you might never get a cancer, while your sister might be positive and she might get a cancer. So people need to understand this. There is something called reduced penetrance, where one person shows the disease and in another person the disease doesn't manifest. For example, in a BRCA1, one woman might develop breast cancer at 45. Her brother is also BRCA1 positive, and the risk of prostate cancer in BRCA1 men is 20%, and it is a very high grade prostate cancer when it comes to them. While this person who is BRCA positive, who has been told that he has a very high risk of prostate cancer, and he should every year undergo the PSA and prostate MRI, might never get prostate cancer. The risk is 20% and he might never get it. While his sister might get breast cancer at a very young age. And that could be because there is a different penetration of the gene in different people. And diagnosis of hereditary diseases, if it is a single gene that is defective, not a multitude of genes, but a single gene is defective, then you might not pick it up on the test. There are parents who get their fetuses checked for cystic fibrosis. Say a couple have two children with muscular dystrophy, two children who are absolutely bedbound, handicapped, and they want a healthy child, then they might subject their fetus to genetic testing. And muscular dystrophy, spinal muscular dystrophy, is a single gene disorder, and it might not get picked up, but it might get picked up. So people still take a chance and get the test done. But when there is a single gene disorder, then it might become difficult to pick it up. And previously, BRCA, breast cancer, was thought to be a single gene disorder on BRCA1 or BRCA2. And now we know that there are at least 20 gene defects which can result in breast cancer. It doesn't necessarily need to be BRCA1 and 2. So these days, we don't do single gene panels, we do multi-gene panels. And in addition to that, it's lifestyle, environment. Say, for example, both me and my sister are BRCA2 positive. Our risk of breast cancer is, say, 40%. For example, each of us is being given a risk of 40%. My sister is extremely slim. She had 3 children. She breastfed all her children. Her risk automatically goes down because a lifestyle and environmental risk is very low, though genetic risk is high. While say I have a genetic risk at 40% of breast cancer and I'm obese and I have not breastfed my children, I have not had too many pregnancies and then other issues, I have a very bad lifestyle, then I'm adding on to my genetic risk. So in addition to the genetic risk, the personal history, the environmental factors and lifestyle also play a role. And so coming back to the same question, what's hereditary and what's familial? In hereditary, you know which gene is defective. In familial, you don't yet know which gene is defective, either because we don't yet know, the technology is not good enough and we might know in future, or it is not a single gene which could be identified. It's a multitude of factors. Whatever it is, they both, cancers can run hereditary with a known defect or in the family. Now, something called hereditary cancer syndrome, where the cancer syndrome runs in families, and they are mostly predominantly autosomal dominant inherited. And so far, more than 50 cancer syndromes have been identified. Most of the syndromes identified happen to Jews. Thankfully, in India, we have very small Jewish communities. So I very rarely come across Jewish families in Hyderabad. But it is true that a lot of cancer syndromes, Ashkenazi Jews you see, and I suppose each one of them has got a cancer syndrome running in them. And that's probably because of very close-knit marriages. While many X-linked and autosomal dominant and autosomal recessive non-cancerous genetic disorders I see in the Muslim community, where the consanguinity marriages are very, very common. But we're talking about cancer syndromes, and about more than 50 are identified. From gynecological point of view, the HBOC, hereditary breast ovarian cancer syndrome, and the Lynch syndrome are important for us for our day-to-day practice. And if you think what's happening in these cancer syndromes, there's just 2 or 3 words I would like you to remember. There is mutation in the tumor suppressor gene. That's typically the P53 in general in sporadic cancers, but in familial and hereditary cancers, there are other tumor suppressor genes where the mutation happens and the gene is not able to suppress the tumor, or there is a defect, mutation in the DNA repair genes or the mismatch repair genes. These are the words that geneticists will use on a daily basis. Most of the hereditary cancers are autosomal dominant, and that is why if your mother or father, one of them has it, it's enough to pass it on. So every person who is positive for a cancer gene, we tell them at least half their children will be positive. So they need to get their children tested once the children cross 20 years of age. An incomplete penetrance, which means if 2 or 3 or 4 of their children or siblings are positive, not all of them will get the disease because the gene doesn't penetrate equally in all of them. And the common ones are Bracha. And surprisingly, the very common one, the Bracha gene mutation, typically the patients see you and me, the gynecologist, because we deal with breast and ovaries all the time. But only 5 to 8% of breast cancers are due to Bracha. The rest are sporadic. The moment I talk about cancer screening to my patients, be it pap test, or if I say annual ultrasound from the age of 40, or I ask them to go for a mammo, the first thing, we have no family history. As if that's a God's grace or a blessing. I think what makes you think it's only the family history which makes you have a cancer. They're like, no, doctor, nobody in my family has a cancer. And you tell them 95% of cancers don't need a family history. Then the first thing is, I lead a very healthy lifestyle. And you think just leading a healthy lifestyle is not enough to prevent a cancer. But people seem to think if nobody in the family has a cancer, you won't get it. That's absolutely not true. And so for a gynecologist, the two most common cancer syndromes are Bracha and Lynch. And we see both. We see in Bracha, we see breast and ovary, and in Lynch, we see uterus. Colorectal cancer, the CRCs, colorectal cancer due to Lynch is only 2 to 3%. The rest, 97% of colorectal cancers are sporadic and have nothing to do with Lynch. And again, Lynch is not common at all in India, thankfully. The less common ones, I won't name them, but at some stage in your life, you might have come across people. There is someone with thyroid cancer, adrenal cancer, and an appendix tumor, and you think definitely they've got something called carcinoid syndrome and stuff like that. So in our tumor boards in the cancer department, we do come across the less common cancer syndromes as well. But a routine gynecologist, a generalist, will typically see the breast and ovary or sometimes the Lynch. And yeah. And then if you look at breast, what cancers does the Bracha gene defect cause? Obviously breast and ovary. And in the men, it significantly increases the risk of prostate cancer and also the risk of melanoma. Melanoma is one of the worst cancers to have because it causes distant lymph nodal mets and it's quite a difficult one to treat. Lynch syndrome, again, uncommon in Indians, causes breast cancer, ovary cancer, especially colon cancer, and the risk of uterine cancer is nearly 70%. BRCA positive people are also at a high risk of pancreas. So we should not forget screening their pancreas and an annual ultrasound scan. Same with Lynch, pancreas, stomach, and some other rare cancers. So from our point of view, the BRCA and Lynch are the ones we mainly need to focus on. And BRCA 1 and 2, they cause a small percent of breast cancers. But when you have BRCA, your risk of breast cancer goes up significantly. It would be a surprise if you're BRCA positive and you don't get breast cancer. And half the people also get ovarian cancer. If you have, say, for example, I'm BRCA 1 positive and I have a brother, then his risk of male cancer is nearly 8%, so that's significantly high. High risk of prostate cancer and pancreatic cancer. And the things you normally notice in BRCA, one is the cancer happens at an early age. By the time they hit 40, 41, the cancer diagnosis is already there. BRCA 1 is far worse than BRCA 2. one is a head to, you can remember it that way. So if someone is BRCA1 positive, the risk of breast is 85%. They're like ticking time bombs. You don't know when that breast will explode. And risk of ovarian cancer is 50%. And remember, ovarian cancer is a silent killer and you don't know when it will hit them. And these breast cancers are pretty bad. They're triple negative, so you can't put them on tamoxifen or aromatase inhibitors. They don't do well. They need surgery, they need chemo, they need radiation therapy, but you can't do the hormone prophylaxis because they're triple negative. BRCA2, usually this disease is a bit later, 50 to 60s. The risk of breast cancer is not 85, but 60%. The risk of ovarian cancer is around 15%. And again, high risk of prostate in men who are BRCA positive, high risk of melanoma. So when it comes to men who are BRCA, the BRCA1 doesn't do much to them. The BRCA2 is not good for them. When it comes to women, BRCA1 is worse than BRCA2. And what do? This is probably the most important slide of my presentation because this kind of summarizes everything a gynecologist should know about what to do if someone is BRCA1 or BRCA2 positive. One, right from the age of 25, you ask them to have an annual breast MRI. How feasible it is in towns and districts, I don't know, but in cities, there is breast MRI happening on a regular basis. And there are some specialist radiologists who specialize in breast MRIs. So you get them to do MRIs, and MRI because there is no radiation. You get really good pictures, you get really real clear views. And then there is no risk of radiation because you can't keep on subjecting these women to radiation when you're going to screen them for such a long time. And then a mammogram starting at the age of 30. And you might ask, why do you need mammogram if they have an annual breast MRI? And I don't know the answer to that question. Probably that is for people who don't have the MRI. And for ovarian screening, ultrasound and CA125 every year starting from age 30. I tell all my patients that they need an annual ultrasound of the abdomen and pelvis every year from the age of 40. There are so many organs in the abdomen, and one annual ultrasound is enough to probably pick up a lot of early changes happening inside. But if that woman is at a high risk of ovarian cancer, then get them to scan on a yearly basis. But then you think, is that enough? Will an ovarian cancer wait for a year before you pick it up? Especially when it is silent and there are no symptoms. So from ovary point of view, it's quite difficult to screen. There is no actual screening test. CA125 is normal in most early ovarian cancers. So we still don't know how best to screen for ovarian cancer, but you have to do something. You cannot just wait for an ovarian cancer to happen. So you get them to scan regularly. But if someone is BRCA1, especially BRCA1 positive, you know their risk of breast cancer is very high, then you can actually treat them. You can actually treat them with anastrozole, or you can treat them with tamoxifen. You can treat them with SERMs. But textbooks say the maximum duration of treatment is 5 years. You should not be giving this medication to anybody for more than 5 years. And if you think because of the side effects and other issues on various other organs, and if you think, okay, at the age of 22, I put her on tamoxifen for 5 years, and then what happens after that? So it's difficult. We don't yet know how best to medically stop these BRCA positive women from getting breast cancer if you don't want to remove their breasts prophylactically. But maybe time will tell. But currently we put them on 5 years of tamoxifen or anastrozole. Obviously, we know COCP is protective against ovarian and endometrial cancer. And even 6 months of COCP protects women from ovarian cancer and reduces the risk for the rest of their life by 50%. I take every opportunity to put every woman I know who is eligible with no contraindications on COCP, either to regularize periods or for contraception because of the cancer protective property. And I try and do it for at least 6 months. If somebody is at a very high risk, is BRCA1 or BRCA2 positive, and you really don't know when they might get this breast cancer, you know they get it young. once they complete their family, I strongly advise them, and in fact, all the colleges strongly advise these women to have mastectomy with reconstruction or implants. That reduces their risk significantly. And if someone is BRCA1 positive with a very high risk of ovarian cancer, obviously the risk is 40%, 40 to 60%, then we remove the tubes and ovaries at the age between the ages of 35 and 40 for BRCA1 and 40 and 45 for BRCA2. You might think, what about these women becoming menopausal? Then obviously you treat them with you give them osteoporosis prophylaxis. Or if they are BRCA1, the tumor is not hormone sensitive, so you can give them HRT. If the breast cancer is not hormone sensitive, there is nothing stopping you from giving HRT after you have removed the tubes and ovaries. And options for these women, again, I'm going through this again: prophylactic, bilateral mastectomy. Recently, I'm seeing Indian women coming forward to bilateral prophylactic mastectomy if they are BRCA positive. And some of them say no to implants and reconstruction. They are like, just leave me alone, I'll stuff my bra. Some of them are keen for implants, and then they get to choose a size which looks good on them. So good, they get a choice there. Obviously, the skin has to stretch enough to take an implant, but most of them get really beautiful shaped breasts afterwards. And these days, I'm doing more bilateral prophylactic salpingophorectomies, laparoscopic. In UK, we used to do them a lot. There were a lot of genetic tests happening, a lot of BRCA1 and 2s identified, and a lot of them undergoing prophylactic BSO. And if they were less than 40, we would just remove the fallopian tubes. If they were more than 40, we would do BSO, and used to do them a lot, actually. One whole theater a week was just for prophylactic reasons. In India these days, on and off in between, BRCA positive women come, we counsel them, and we remove the tubes and ovaries. And just look at these numbers. I want you to focus on this. If you do bilateral mastectomy, you're reducing the risk from 80%, you're reducing it by 90%. So 80% becomes 10%. And that 10% is just in case you have left any breast tissue or there's any breast tissue in the axilla. And in the woman, if you do BSO, you have reduced the risk of ovarian cancer by 96 to 98%. And the risk of 1 to 2% is because there's a risk of primary peritoneal cancer. In general population, to screen for ovarian cancer, nothing much. You do an annual scan, you do an annual CA125, whatever you do, it's not good enough. But in these women who are high risk, who are BRCA positive, who are HNPCC positive, who are Lynch positive, then you know that they are high risk of ovarian cancer. You just can't sit on them waiting for them to get ovarian cancer. It's a silent disease. So less than 40, we remove the fallopian tube. We know that fallopian tube is what causes ovarian cancer. More than 40 years of age, remove the ovary as well. If they are BRCA1 carriers with 50% risk of ovarian cancer, right from 35, you can remove their ovaries, and if necessary, put them on HRT and regularly screen them for osteoporosis. So risk reducing salpingectomy has been fashionable to reduce the risk of ovarian cancer. We've been talking about it a lot. And any hysterectomy you do, if you're keeping the ovaries, keep the ovaries, but take the tubes out. Any hysterectomy, BRCA1, 2, irrespective, because tubes are what cause ovarian cancer. The epithelial ovarian cancers start in the fallopian tubes. Normally, what would you do for breast cancer screening on any woman? We would talk about monthly self-breast examination from the age of 20, and then examination by the doctor, maybe once every 6 months, 12 months. And then we talk about mammograms from the age of 45. And nothing, BRCA1 positive, BRCA2 positive, no positive family history, anybody, any woman should be doing, every woman should be doing a self-breast examination from the age of 20. And then I usually tell people that on screening, we pick up rice grain sized tumors as well. On a breast MRI or on a mammogram, you can pick up something as small as 2 to 3 millimeters, while an examination with the hand will only tell you something which is more than 2 centimeters. So there is an importance in undergoing screening, and screening is recommended from the age of 45 in general population, but in high risk population, obviously, it's expedited. We do annual screening, we do annual breast MRI. And mammogram, like I said, is being recommended for general population from about 45 years of age. Indian ladies, I noticed, are slow to pick up on prophylactic mastectomy, but it's very common abroad if you're BRCA1 or 2 positive, because when you know either of your breasts could turn into a cancer anytime, even if one breast turns cancer, the chances of other breasts becoming cancerous is nearly 25 to 30%. And you're done with your breastfeeding, then why do you want to keep a part of the body which hasn't got any role in your day-to-day function? It's not your heart, lungs, or brain or kidneys. You don't need your breast to live. Get them out, get implants in, so no one else will know other than yourself that you had potential cancer which you got removed. So this is something we gynecologists should encourage, because if they get their breast removed, these women have a very normal, a long life ahead. And I'm sure we all know these both beautiful ladies. Angelina had a very strong family history due to BRCA positivity. She knew she was a very, very high risk for breast cancer and ovarian cancer, and she prophylactically had the mastectomy and had implants. Gautami, on the other hand, had a very strong family history of breast cancer. Both the parents are doctors, and so I think they had a lot of background medical knowledge at home. And I met her once, and she told me that her mother advised her to undergo screening on a regular basis, and her mother would also undergo screening on a regular basis because of their strong family history of breast cancer. And though her mother was spared, Gautami was found with a very small tumor in her breast at a very young age. She underwent surgery, radiation, chemo, and since she's been talking a lot and promoting breast cancer screening. And because the lump was so small, in spite of all the 3 different modalities of treatment, she survived, and she's now with us basically because she picked it up early. So both these ladies should be our examples for ourselves and for our patients, that if you think there is something running in your family, take precautions, take action, avoid it, prevent it, get it out soon. And talking a little bit about Lynch syndrome, because Lynch syndrome has a very high risk of endometrial cancer. Lynch syndrome causes colorectal cancer, and the risk of colorectal cancer is 80%. So if you have Lynch syndrome, you will have an intestinal cancer undoubtedly. And before the intestinal cancer happens, it'll be the polyps in your colon will give rectal bleeding. So test the stool test, fecal or gall blood test, a colonoscopy, endoscopy, these are mandatory. But the risk of uterine cancer is 70%, and the risk of ovarian cancer is 10%. Who on earth would take a risk of 70% uterine cancer? So the very strong recommendation is get that uterus out the moment the woman finishes her family, and get the ovaries out at the age of 40. And then if you want to know more about what tumor, what the genetic defect causes Lynch syndrome, this is the detail. And most Lynch syndrome patients are less than 50. And therefore, if they are young, they want their uterus, they need to have a family, do regular ultrasound scans, and then annual endometrial sampling, starting right from the ages of 25. And if you think if there's a Lynch syndrome in the family, these young people need to start colonoscopies and endoscopies from the age of 25. And from a gynecologist perspective, TAH-BSO for all Lynch syndrome patients if you don't want them to die of cancer. Some of these, you think it really kind of swirls your head. You think, what on earth is happening with these syndromes? Familial adenomatosis polyposis, more than 100 polyps in the colon, risk of colorectal cancer by the age of 45. And then you want to do this, so many cancers at risk. And annual colonoscopy from 20 years of age. Go try telling a college student that there's a strong family history of cancer, have an annual colonoscopy. Otherwise, by the age of 45, you'll get colorectal cancer. And you think, oh my God. But they have to, I wanted to show you this picture of a transected colon. See, the entire colonic mucosa is nothing but polyps. And you think, just thank God we don't have any of those genes in us. So many other syndromes, so many other cancers associated with them. So if you find a person who has got a strong family history of cancer, or somebody with a brother or a sister who had multiple 2-3 cancers in them at a young age, then you think, should I get this girl tested? And again, Lifromini is one of the very bad cancer syndromes. And your red flags, when should that alarm bell in you ring, is when the cancer happened to a family member early in their life, multiple cancers in different people or the same person. And then you start to hear about rare cancers, unusual colon cancer in a 35-year-old. And you think, why should a 35-year-old have colon cancer? Colon cancer is not rare, but then say a thyroid tumor associated with an adrenal tumor, and you definitely think something is going wrong in that family. So you won't know these warning signs. You won't highlight, you won't think about the warning signs if you're not aware of them. So, and you won't be aware of them if you don't take a family history of cancer. So not just because I sit in a cancer clinic, but even when I was taking a gynae history, family history and personal history are important. And in the family history, taking a history of cancer, it only takes 1 or 2 minutes, because most people say, no family history, or one grandfather, one parent, one aunt, someone. The moment they start to talk about their partner side, I say, no, on your side, your mother's side, your father's side. That's it. Very clear. If you're very clear in your questions, you get clear answers, and it only takes 2 to 3 minutes to take that family history, but it's very, very important. And so what? You've identified, you realize something is not right. There is a strong family history of cancer, but you're confused. You don't know what to do. Send them to a geneticist. At least you've done your bit. You said this particular geneticist in NIMS or this particular hospital deals with these kind of things. Go to them. And if you don't know a geneticist or a genetic counselor, then send them to us oncologists, because we constantly deal with these things. And it's very important, you sometimes people say, okay, I'll go for this test, I'll pay 20,000, I'll contact the rep, I'll get the test done. Once the test done and it comes positive, it's a huge drama after that. They behave like the life has fallen apart. They behave like you've ruined their life. I've seen a few people get divorced after a positive test, and lots of drama goes around it. So they have to really think before they go to the test. They need to know that the test might come positive, the test might come negative, the test might come something called a variability of unknown significance. And you think, what on earth? What is unknown significance? What does that mean? And then they might not get insurance, health insurance, if the insurance company knows they are positive. So a lot of things. And some people worry that if the mother is positive, or if they are positive, they might never be able to get married, knowing who will marry if they know you have a positive cancer gene. Lot of different things, lot of different issues. And then the test, every 3 days or 4 days, I get a test from the genetics company saying they are positive for a pathologic variant or they are negative, which is good. Positive is good. I can explain, I can tell them what to do. Negative is even better, because that's good news. But then so many times you get a test report saying VUS, variant of uncertain significance, which means they saw something, but they don't know what it is, and they don't know what cancer it will cause. And you think, if you don't know, how am I supposed to know? And if I don't know, what is my patient supposed to know? And you think, this much effort goes into this test, it's expensive and everything, and then the result comes as variant of unknown significance. So we tell them, look, there is something wrong, but the technology is not advanced enough to tell us what exactly will happen because of that. Maybe nothing will happen, maybe something will happen, so just be careful, which is what we would have told even if the test wasn't done. So the VUS is a nuisance, it's a nuisance report, but I don't think anything can be helped unless we discover more and more genes and what diseases they get. But you should be prepared. Only the other day I did a test on 2 sisters got the test done because both of them, the mother and mother's sister, had ovarian cancer. The mother is now a patient of mine with ovarian cancer. So both the daughters, 2 daughters, both of them got tested. And one of the daughters said, actually, my husband's mother also had ovarian cancer and his grandmother had breast cancer. It's because these 2 are female organs, I didn't think my husband needed the test. And I said, no, your husband is at risk of prostate cancer if he's BRCA2 positive, and his mother had his mother had ovary, his grandmother had breast. So please get him tested as well. So the husband and husband's sister also got tested. These 2 sisters with 2 ovarian cancers in the family had VUS, variant of unknown significance. And they were like, we spent 50,000 on this test. And it says, we don't know what's exactly wrong with you, something is wrong. Well, her husband and his sister, both of them had positive BRCA2. And then I got him screened for prostate, pancreas, and told him that he's at a high risk of male breast cancer and melanoma, and gave him a chart of how frequently he should do what test. And I'm going to remove his sister's breasts and tubes and ovaries. That's planned for some time in future after extensive counseling. So the positive test, you can work on it. The negative test, you can work on it. But the VUS always causes confusion and some degree of unhappiness in the people who go for the test. But what each and every report from these genetic companies says is, please ask for an update on an annual basis. So they're saying, look, we got your gene profile, we worked on your genes, we tested your genes, we found something. Even for the positive report and negative report, they say, please ask us for an update annually. This might be charged extra or might not be. So what they're saying is next year we will know more. We will know more about genes. We will know more about what gene defects can cause what cancers. Now that we know what's wrong with you, we will use the same panel of genes. Of course, genes don't vary. You know, we have your blood with us. We have your samples. We will just update our report. So they do tell you that for what you paid this year, we will keep you updated on an annual basis. You just have to get in touch with us. That's how good these companies are with their reporting. And therefore, with VUS, you actually don't know what exactly will happen to them. But then as time goes by, we might know more. So we tell them that, look, something is not right with you genetically, but it is not a strong association with any particular cancer. So just undergo routine screening on a regular basis. And what are the testing logistics? You identify a patient. Till to date, no particular corporate hospital or any of our local diagnostic centers do it. At least I don't send them to anywhere local because these tests are expensive. The methodology needs to be standardized. I only send my patients to internationally reputed companies because they do follow some standards. And in India, for example, at this moment of time, these are the 3 companies who do the test. So basically, you give them the contact, the name of the company, and say, contact this company, or give the name of the rep, name and number of the rep. The rep will get in touch with them. Then the genetic counselor will call them and ask why they want the test. Say, for example, I have absolutely no family history of cancer, but I tell them, look, I'm frightened I'll get cancer. That's why I want it. They won't do it. Even if I'm prepared to pay, they will not do it. They will only do genetic testing if there is a family history, if they think there is a hereditary or familial risk. Only if they're convinced that this person really has a strong family history, they will come to the patient's house, take the sample, and then they'll send a copy of the report 3 to 4 weeks later to the person and also to the doctor who referred. And this test will not be done without a doctor's prescription. So that is the methodology. So if you think any of your patient deserves this test, then you don't need to do anything. Just give them the name of the company and the rep, and they will take care of it, and you will get a report and the patient will get a report. Should you be doing single gene versus multiple gene? Previously for breast cancer, ovarian cancer, we used to do single gene, BRCA1, BRCA2, 2-gene test. It was less expensive. But then we realized that breast cancer is not just BRCA1 and 2. There are so many other genes. So your BRCA1 and 2 mutation might be perfect, but then you could have other gene defects which could cause. So these days we only go for multi-gene panels. And if you think what is the harm in doing multi-gene panel? One, it is slightly more expensive. It's a comprehensive panel. It looks for 32 genes. Some companies are looking for 50 genes and so on. And then you tell them which cancer is at a high risk in their family, and they will target those particular genes. And with multi-gene panel, the advantage is more cost effective. For a price, you get a lot of genes tested. So it is more expensive, but it is more cost effective either. But then you get a lot of these VUS, you know, this gene, this gene, this gene, this gene. So many gene defects are there, but we don't know the significance. And you think, I'm just more confused now. I don't know what to tell my patient. So like we discussed, genetic cancers or disorders, there's so many of them which run in the families, but mainly for us, from our point of view, it's breast, ovary, And when do you refer to the geneticist? When there is, this is the list, if you want to take a picture, this is the picture of one slide you need to take. But if you think there is more than 2 relatives or one person who at a very young age got breast or ovarian cancer, a lot of colorectal cancers in the family and uterine cancers, then it's enough. Sometimes you think, okay, I think she's at a high risk, I'll refer her. The genetic counselor can take care of it. If they think she's at a low risk, they'll tell her, look, you came to me, that's good, we talked, you're not at risk, fine, just leave it at that. So nothing wrong in referring somebody if you think they are at a high risk, no harm done. And this is where I'm going to stop and take questions.
Thank you very much, ma'am, for the wonderful presentation. We are very honored and learning to hear you, ma'am. Ma'am, if you allow me, then we'll take the questions.
Sure.
Yeah. Oh, ma'am, we have a first question. Any current screening procedures to detect ovarian cancer at an early enough stage?
At an early enough stage, the only ovarian cancer screening test is an ultrasound scan. And the problem is, how frequently can you do an ultrasound scan? Because other than ultrasound, there is no other test which will screen for ovarian cancer. And say my ultrasound scan shows normal ovary this month, then maybe you'll say come after 6 months, or you'll say come after 3 months. But between now and in the next 3 months, I could get an ovarian cancer. So there is actually no screening test for ovarian cancer. We say from the age of 40, get an ultrasound scan on a yearly basis, and then tell every woman, warn them, teach them that these 5 abdominal symptoms, feeling of fullness, bloatedness, lack of appetite, nausea, and needing to urinate more frequently. If any of these symptoms last for more than 3 weeks, then they should get an ultrasound scan done. As such, screening to catch ovarian cancer at an early stage, other than a transvaginal ultrasound scan, there is nothing.
Thank you very much, ma'am. We have one more question. Oral contraceptive use in women with ovarian cancer with a Bracha mutation will benefit or reduce the magnitude of risk?
The question is not very clear. Does this woman already have ovarian cancer, or she is BRCA positive?
I think Bracha mutation she have.
If she has BRCA mutation and she is less than 40 years of age and you don't want to remove her ovaries yet, then putting her on COCP is good for her ovaries. And what people worry about is if the COCP will increase the risk of breast cancer. But you also need to realize that most BRCA breast cancers are not hormone receptor positive, so the pill will actually not increase their risk. So if someone is BRCA, especially BRCA1 cancers, the breast cancer is not hormone receptor positive. So being on the pill will not increase the risk of breast cancer, but being on the pill will reduce the risk of ovarian cancer. But until the breast cancer hormone receptor status is not known, you won't know if you should put them on the pill or not, just in case the breast cancer is hormone receptor positive. So it's a very difficult thing to judge. Only if you know that the breast cancer is not hormone receptor positive, you can put them on the pill to protect them from ovarian cancer. So usual scenario is if someone is BRCA mutation positive, they would have had some treatment for the breast cancer. Usually you know it after the breast cancer has happened, in which case the breast is gone and you know that if it's hormone receptor positive or negative. If it's hormone receptor negative, then you can happily put this woman on the pill to reduce the risk of ovarian cancer. But the risk is still very high. It only reduces it by 50%. So the 40% risk might go down to 20 or 30. So at some stage, you have to remove her tubes and ovaries.
Yeah, thank you very much, ma'am. I think the next question is also likely the same. When can we do the salpingophorectomy to reduce the risk? I think.
Less than, it depends. Okay, it depends on if they are BRCA 1 or BRCA 2. And these days, you will clearly know if the person is BRCA 1 positive or BRCA 2. That answer is very clear in almost any genetic test. If the person is BRCA 1 positive, the risk is very, very high. So after the age of 35, you take out the tubes and ovaries. In BRCA 2 carriers, after the age of 40, you remove the tubes and ovaries. So 35 for BRCA 1, 40 for BRCA 2. And if the woman is less than 35, then you just remove the fallopian tubes and keep the ovaries until they reach the age of 35 to 40.
Thank you very much, ma'am. There are no more questions from the delegates, ma'am. Then if you allow me, then we'll close this webinar.
Thank you.
Yeah, thank you very much, ma'am. If there are any questions from the delegates later, we'll definitely share with you.
Sure.
Yeah. Thank you very much, ma'am, for a wonderful presentation. We look forward for your continuous support and have a good day. And many thanks from the SHIELD team. I also thank all the delegates for the active participation.
Thank you.
Thank you.
Thanks, Chitra.